I'm going to make a pitch to the individuals in the room who are past their one and only attack. This is an incredibly important topic because at one point, all of us, either ourselves or a family member or friend, was in the emergency room or in the hospital, and somebody said either didn't recognize transverse myelitis or the optic neuritis, or once recognized it, wasn't entirely sure what to do about it. And we are trying desperately to fix that issue. It is something that needs a lot of attention, but it is also something, as Dr. Wingerchuk will explain, has relatively limited data in terms of guiding treatment decisions. This is a very important topic, and we're thrilled to have Dr. Dean Wingerchuk from the Mayo Clinic Scottsdale here. He's a professor of neurology and has been working on issues surrounding neuromyelitis optica and transverse myelitis for years. As part of a consortium, he and I and Mike Levy have worked on for the last several months and year different ideas on how could we answer this question. And so we invited Dean to give the talk, Treating Acute Inflammation, and give you a sense as to what do we know, what do we don't know, and what do we have to solve. So I'll turn it over to Dean.
Well, good afternoon, everyone. I have the good fortune, I think, of speaking right after lunch, so you won't quite be falling asleep yet, right? It'll be half an hour or so. Happy I'm just standing up. That might prevent me from falling asleep. All right, so thank you to Dr. Greenberg and those involved in inviting me to talk. And so what I'm charged with covering today is the topic of treating acute inflammation. So I have here some disclosures. Most important, I guess, is simply to tell you that right now there is no treatment that's actually formally approved by the FDA, the Food and Drug Administration, for treatment of an attack of any of these disorders. So everything that we're doing, every intervention that I mentioned, will be what's called an off-label use. But as you know, that's a common issue. So what will I cover? I'll talk a little bit about the importance of acute inflammation, but then focus on treatment options, really on these four areas: corticosteroids, IVIG, plasmapheresis or plasma exchange, and then so-called immunosuppressive therapies, and if they have any promise in treating inflammation in the future. So you had, as Dr. Greenberg said, your introduction this morning to sort of the categorization of these types of immunologic disorders, and this is not a comprehensive list by any means, but this is a list that encompasses what we call the inflammatory demyelinating diseases of the central nervous system. And what's common to most of them, in fact, is their tendency to cause, number one, inflammation, and then number two, to relapse. Though there are some individuals that will experience an episode of, for example, transverse myelitis as their one and only event, that is still relatively uncommon in the whole scope of these disorders. So I think for most people, for most individuals, at some point, this topic is indeed germane. So acute attacks generally, almost without exception, are the presenting feature of all of those inflammatory diseases. And clinical relapses or flare-ups are the hallmark. It's what people experience and what we as neurologists look for to identify that the disorder is in fact a relapsing disorder and that it is in fact active. Now, there are a variety of definitions that have been used to describe an acute relapse or an acute attack. Generally speaking, new or recurrent neurological symptoms that persist continuously for at least a day and can't be attributed to another cause may be a new attack or a new inflammatory event. And that other cause could be something like a fever or an ongoing other medical illness, which sometimes can bring back neurological symptoms that a person previously experienced. Sometimes it can be something like the effect of a medication. But if those things are ruled out, it's likely that those new and persistent symptoms are being driven by, in fact, new disease activity. So as I mentioned, it signals new disease activity. And the common elements for most of these disorders are an inflammatory infiltrate, so there's new inflammation, there's a flu in the brain or in the spinal cord or in the optic nerve, consisting usually of the kinds of cells you heard about this morning, in MS in particular, T cells and macrophages, and then in most of these conditions also demyelination, interruption of the continuity of myelin on the nerves. For some of these diseases, we know there are specific elements that are important, and this is where we're starting to make progress or get smarter about not only diagnosing these diseases in the first place, but also what kinds of treatments will be most effective for them, and you'll see what I mean in a moment. One example is that we know in some disorders, in particular neuromyelitis optica, that deposition of antibodies and activation of this thing called complement are very important. And relatively speaking, they play a much more important role in NMO than they do in multiple sclerosis. Now, attacks are obviously relevant because they cause symptoms. Relapses or recurrences are relevant for a variety of reasons. Otherwise, I mentioned before that in multiple sclerosis, it's how one defines the relapsing remitting course of the disease, and that dictates disease-modifying therapy. It tells us that this person has a relapsing disorder and that it should respond to an ongoing disease-modifying preventative type of therapy, which is the topic of the next presentation. We know that in MS, early attacks do contribute to some impairment, but later in the disease, it's unclear what impact they have. And so one of the working hypotheses now in MS is that treating MS early and preventing attacks might actually delay or prevent or somehow alter the activity of this later progressive phase, which is where most people with MS accrue their important and lasting disability. In NMO, though, it's different. People generally don't get this secondary progressive gradual course. Almost everything that happens that affects people with NMO is related to a relapse. We can see relapses in some, but not all instances. In multiple sclerosis, for example, the arrows here are pointing to lesions in the spinal cord, two small separate lesions that are responsible for acute attacks of myelitis or spinal cord inflammation. And in the middle panel here, and this MRI is meant to distinguish the two disorders, but this is a typical lesion of neuromyelitis optica in its acute phase. So sometimes when there's either uncertainty about exactly what's going on because of, again, the potential effect of an underlying infection or unusual symptoms, imaging might help in providing some additional evidence that there isn't indeed a new attack. Understanding the profile of how relapses behave is important. In multiple sclerosis, the evolution of attacks usually is over days to weeks. So gradual worsening over days, a plateau, and then improvement over weeks. Occasionally, attacks are, of course, much more rapid, and especially in non-multiple sclerosis illnesses like NMO or idiopathic transverse myelitis, where the abnormalities can come on, the symptoms can come on quite suddenly over hours or even minutes. Most of the time, those attacks, regardless of the disease, will again plateau in a couple of weeks. With or without treatment, in multiple sclerosis, there's generally gradual recovery, with most of that recovery occurring within the first 3 months, and then a slower pace of recovery afterwards. But of course, there's a wide spectrum. There's some people that are fortunate and have a relapse recover completely. There are others in which the relapse does not improve at all. But that's the general time frame or temporal profile. So with that introduction of just understanding what relapses are and what they mean and how we interpret them, I'll just cover briefly these 4 categories of treatment, which I'll bet most of you are at least somewhat familiar with. And the first of these is corticosteroids. And I think you know these are not sort of bodybuilding steroids. These are what are called glucocorticoids, which are related to what your body makes naturally from the adrenal glands. And examples would be methylprednisolone, otherwise known as solumedrol, dexamethasone, or prednisone, which is taken orally. And the idea here is that basically, as I mentioned before, there's inflammation in the brain. There's a flu in the brain or the spinal cord, and you're taking this large hammer and hitting it with a very broad spectrum of effects. So in other words, there's lots of things that anti-inflammatory types of steroids do. We know that they bind to certain receptors in cells, and we think that their major effect is to shut off a whole bunch of genes that are involved in causing inflammation in the first place. And we know that they reduce swelling. So sometimes we'll see that a person has an acute attack, and when we look at the MRI, we see a lesion, and then we see what looks like swelling around it. And when we give steroids, we see that the person makes a very rapid improvement over the first couple of days, and then things plateau, and they may or may not improve after that. Probably that initial response was related to the swelling or the edema that's around that lesion, which very promptly responds to the steroids. Now, the evidence is sparse for any of these interventions, as Dr. Greenberg mentioned, but we do have some evidence that is high level for both multiple sclerosis and optic neuritis in particular, where people have done very large controlled trials where somebody's presented with optic neuritis or an attack of multiple sclerosis, and then they were randomly allocated to either a steroid or a placebo or an early steroid or a late steroid or a high dose or a low dose or IV versus oral, a whole variety of different approaches. What I can tell you very simply is that in multiple sclerosis at least, corticosteroids seem to speed up recovery from attacks. They probably do not have a significant, at least major impact on the ultimate recovery from an attack. So if somebody has a mild event of multiple sclerosis or a moderate event, that attack will, a year later, very likely be the same with or without steroids. But of course, attacks impair function, they're uncomfortable, they cause people to miss work, etc. So treating those and speeding up recovery can make a major improvement in quality of life. And then there are, of course, attacks. Not every attack is the same. Some attacks are sensory attacks and don't impair function very much. Other attacks are much more important, of course, because they affect things like vision or motor function. And just intuitively or emotionally, we feel more compelled to want to treat those, even though we're less certain of exactly what we're doing in the long run. I can say, though, that there's no right way to give steroids, and no perhaps wrong way. In other words, the benefit that's seen is approximately the same, whether one gives intravenous or oral steroids, although IV steroids typically are easier to administer in an equivalent dose. Low versus high dose, and I'm talking here in particular about intravenous preparations, and then duration, 3 versus 5 versus 7 days. It all works about the same. Our standard therapy, and most of you will probably be familiar with this, is the equivalent of a gram or 1,000 milligrams of IV Solumedrol a day for 3 to 5 days, infused usually over about an hour. Some neurologists will use a prednisone taper afterwards, so they'll finish the course of IVs and then have the person take oral prednisone for some days after. Now, in most otherwise healthy people, that's not medically necessary, and some people actually prefer to just do the bolus of IV infusions and then stop, because then they can avoid the steroid side effects. But some will have post-infusion symptoms. They sort of crash, they feel lousy, they have no energy, their muscles ache, and some of them may have sort of a withdrawal or an insufficiency related to that sudden stoppage of steroids, and they might do better by adding a prednisone taper to the end. So you'll see and learn about variations in practice in that regard. Now, there are actually very few instances where prednisone should absolutely not be used, but there are some things to be cautious about. So we generally are concerned about people who have known diabetes, because these steroids will make their sugars go up. Active infections, especially bacterial or fungal infections, because these are immune suppressant drugs. Somebody who's been sensitive to steroids before, and that could be in a variety of ways, including the propensity of these drugs to sometimes precipitate major mood changes or even a psychotic type of episode. It's not that common, but when you see it, it's unpleasant for everybody. Kidney problems, liver problems, pregnancy is a relative reason not to give it, though sometimes it can be given, and then uncontrolled hypertension. But by and large, most people actually tolerate infusions of corticosteroids really pretty well. In fact, well enough that if we can give the first infusion to somebody who's otherwise able to not be in the hospital, if we can give them their first infusion in an infusion center, they can do the rest at home. We usually will do some preparatory blood work to make sure their glucose and sugars and things are okay, and then we could administer it, as I said, at any of these sites. Obviously, if they need to be hospitalized for their attack, they'll have it in hospital. There are many potential adverse effects of steroids. If you read about any literature about the adverse effects of steroids, it's basically everything you can think of. But many of them are actually not relevant to a short burst of steroids. Most of them are of concern when one is using chronic steroids for months to years on an ongoing basis. But infusions of steroids can be associated with elevations in blood pressure, blood sugar. Most people experience some tingling either in their hands and feet or around their mouth. Women, for some reason, don't like fluid retention and increased appetite. I'm not sure why. Insomnia, jitteriness, the things that I mentioned before are fairly common. We usually give people medication to help them get through that if they decide they need it. And about one of the worst things that can happen, which is thankfully extremely rare, is basically damage to the bone of the hip, which sometimes requires a hip replacement. But we're talking about events in the 1 per million plus administrations of steroids. So pretty safe. Generally speaking, we think that for most of these disorders, if not all of them, that the earlier one administers the steroids, the more effective they'll likely be. Which brings us to the second treatment, which I would consider a second-line treatment, and that's plasmapheresis or plasma exchange. And at Mayo Clinic, at least, we use this as a second-line therapy for people with any of these disorders who have a particularly bad attack, and especially if that attack is not responding very promptly to steroids. We'll move quickly, sometimes before the steroid course is ended, we'll just abort that and go quickly to plasmapheresis. Now, the rationale here is that for at least some of these diseases, and I would say neuromyelitis optica is the sort of poster child for these, there's something circulating in the blood that we're able to pull off with plasma exchange. And so the rationale is that there's some substance in the periphery in the blood that gets into the nervous system and causes damage, and if we remove those things, we can stop the attack and hopefully reverse its effects. And so there are, we can postulate or develop theories about what those things might be. The leading factors are various antibodies, for example, the antibody that's associated with NMO, complement, this other thing that I mentioned as part of the immune system, and all kinds of other evil humors. Now, there are actually, it might surprise you, some pretty good data to support the use of this intervention in demyelinating diseases, randomized controlled trials, as well as a lot of observational studies. And some of this dates back more than 20 years. Dr. Weiner at Harvard studied people with multiple sclerosis back in the 1980s. They randomized people to get plasmapheresis versus a sham plasmapheresis, and they also were using chemotherapeutic drugs, but basically they found that there was some short-term benefit in speeding recovery from people who had relapses. My colleague Brian Weinshenker published a study in 1999 where he was focused in particular on this category of very severe attacks of whatever demyelinating disease, and I've listed them all here, that weren't responding to steroids. And the idea was that people got plasma exchange or they got a pretend plasma exchange, and they didn't know which they were getting first. If they didn't respond, then they crossed over. So everybody had a chance to get the active treatment. And they looked basically for important improvements in function. I'll skip over the design of the study, but the high point here is that basically, despite these really devastating attacks, about 40% of people responded during plasma exchange, and only one patient responded or improved during the sham procedure, and that was a significant result. So how does this actually work? Well, basically, most people know what dialysis is when you treat kidney disease, and plasma exchange is something like a dialysis procedure. It's essentially using a machine, and there are a variety of companies that provide these little robot-looking machines that that the individual person is hooked up to through intravenous lines. And this can be done in a number of ways. It can be done through general peripheral intravenous lines, usually larger ones, but they are peripheral, or a central line in the neck. A tunneled catheter is sometimes placed for if it's thought that a person's going to need a number of exchanges over an extended period of time. And then they undergo these procedures where the blood is removed through one line and circulated through this machine, spun down. The liquid part of the blood is removed. The cells, the white blood cells, red blood cells, etc., are retained. The liquid part, which presumably has all the bad stuff in it, is discarded. Then they take replacement fluid, which is albumin, comes from blood donors. So that's new liquid, mix it with the original cells, and give it back to the person. So although it's different than dialysis, the process is kind of the same. You're taking out bad stuff, you're putting in, you hope, clean stuff. The risks of plasma exchange are more significant than they are with corticosteroids for certain, in part because of the fact that you're dealing now with instrumentation. You've got to put lines in, sometimes these central lines, and you're manipulating the volume of blood and cells, et cetera, in people, and that requires people with expertise to monitor this. So temporary development of anemia or low platelets that are associated with blood clotting often develop electrolyte changes. And in particular, we worry about complications with the lines, getting an infection or a blood clot in the lines, or developing a blood clot to the lungs or a pulmonary embolism. Now, these are infrequent complications, but they are real. And so, usually we're, again, going to this therapy as a second-line approach in people who are experiencing particularly bad episodes. Now, it's interesting, some of the science behind this. Dr. Wingerchuk noted during his study that, as I showed you the results before, people tended to have sort of an all or none response. In other words, the responders made a pretty good recovery. The non-responders really didn't improve at all with plasma exchange, and there wasn't really anybody in between as sort of a partial responder. And we'd wondered whether or not that had something to do with the underlying disease itself. And in fact, it did. When we look back to see who responded to plasma exchange treatment, it was, first of all, people who had a particular type or pattern of MS we call pattern 2, and you can only diagnose that right now by looking at tissue under a microscope, so you need a biopsy, for example, or neuromyelitis optica. And there's some similarities between these, but those were the groups that really responded. And we think the reason that they responded was because the people with MS that had these bad attacks, and this pattern right here, are the ones that have all this antibody that attacks the nerves, and all this complement that's activated and causing this terrible inflammation. So that's stuff that we know we can pull off with plasma exchange. Other patterns of MS, which don't have that, don't seem to respond. So that sort of makes sense. And the same thing with neuromyelitis optica. Again, we have immune antibodies, immune globulin, so antibodies, and complement. This is a stain for complement. This is what we see under the microscope in neuromyelitis optica, that stuff, that bad stuff, basically attacks and causes damage around blood vessels. That's stuff that we can pull off with plasma exchange. So it does seem to benefit those groups in particular. Not always, but those are the groups that tend to respond. So there were many reports through the 1990s and this decade of people that responded particularly well to plasmapheresis. This is pictures worth 1,000 words, as they say. This is a report of somebody who had particularly bad event of brain inflammation. This is before they got treatment. This is after they got steroids, really minimal improvement. And then after plasma exchange, there was marked improvement. In fact, you can just see a trace of the original lesion there. So they seem to be a responder. Since Dr. Wingerchuk's major trial, which was small but a very difficult undertaking, nobody has ever done another controlled study like that where they compared plasma exchange against sham plasma exchange or another intervention. But there have been a lot of reports of people using this in practice and reporting their results, and the results are really very consistent. People that have bad relapses Some, not all, but some will respond, and the better outcomes tended to be in NMO. We've also seen it, though, work for steroid refractory optic neuritis. We think, as I mentioned before with steroids, as a general principle that early treatment of attacks is better, and we do have some evidence of that for plasmapheresis. So this is a study published last year where they basically showed that when they looked back at their 41 patients that were treated for bad attacks, of which almost 2/3 were better at 6 months, the things that helped the most, or were, well, the things that were the predictors of benefit were early initiation of treatment and already getting better by the time they left the hospital. So again, early treatment seems to be beneficial. So the summary is plasma exchange is helpful for some people, especially bad attacks that don't get better with steroids. Early treatment is predictive of response. Neuromyelitis optica and certain MS patterns are the most responsive. We don't yet know whether there's a role for plasma exchange in treating these diseases as a chronic therapy, in other words, trying to prevent attacks. But there is some interest in doing that, in particular for NMO. Okay, we're getting close to the end. Number 3 is IVIG, or intravenous immune globulin. And many of you will likely know what this is. Basically, this is a pooled blood product. So they take blood pooled from thousands of donors, and they take off the antibodies, in particular the immunoglobulin G, and then they pool it together to make this product. And what immunoglobulin G is, and you probably saw diagrams of antibodies this morning, are collections of these proteins in which they kind of have this Y shape. One end of it binds to an antigen, so a bad target, and the other part binds to immune cells. And so having thousands and thousands of copies of this and putting it into someone's system in an IV infusion sometimes helps these diseases. We don't actually understand very well how this works. This cartoon diagram here is meant to demonstrate some theories about how it works, how it might sort of soak up bad antibodies or block receptors that those antibodies are trying to get to. We don't really know. There are actually very few diseases in the neurological realm, one actually that I know of, which is CIDP, where the FDA has approved this drug as an ongoing therapy, but there's lots of off-label uses. Now, here there again are mixed levels of evidence or degrees of evidence to support the use of IVIG for the kinds of disorders we've been talking about today. There are a few trials looking at adding IVIG to steroids for an attack of MS, and unfortunately that does not seem to work. There are not really good trials of IVIG by itself. So in other words, somebody has an attack of MS, you use IVIG first. We really don't have evidence there. I would say that anecdotally, so just based on reports in the literature, not really big studies, that there are some reports of IVIG seemingly improving attacks in NMO, especially in kids, in ADEM, especially in kids, and in some transverse myelitis. My own experience with IVIG is not particularly favorable, so that's why I've relegated it in this list to a later line treatment. I certainly would try it in somebody who didn't have a clinical response to steroids or plasma exchange, but I wouldn't use it before I used those two. That's my personal practice. The typical regimen I mentioned is an IV treatment, so people get a dose based on their body weight, and there are a variety of ways you can give it, but typically it's given on consecutive days for 5 days. This is quite a safe thing to do. It can also be administered as an outpatient, but of course usually it's given in the hospital. And there are potential side effects with it, though most people will tolerate it very well. Headache's pretty common. Sometimes it even causes some inflammation of the linings of the brain, a meningitis, but not an infectious meningitis, just inflammation, which is uncomfortable. Dermatitis, there's worry that you could get something from those blood donors, some kind of viral infection, for example, hepatitis, HIV, something like that. Obviously, the Red Cross and other organizations that have or are still involved in collecting blood and and then formulating these products with private companies have all kinds of processes and procedures for screening and eliminating these known pathogens or viruses, et cetera, out of that system, excluding them so they won't contaminate IVIG. But there may be things that we don't know about that ultimately will become important. And then there are a variety of important but thankfully uncommon things that can happen. Now, I'll mention that there is some interest, of course, in finding better ways to treat acute attacks and acute inflammation, because the armamentarium we have right now is, number one, not very focused, and so it's not necessarily targeted to the pathology of a disease very well. And number two, it doesn't necessarily help people as well as we want it to. So people have tried other things. This is a report from Dr. Greenberg and his colleagues from their transverse myelitis clinic, where they looked back at patients that they had treated who had had acute transverse myelitis. Most of them, or many of them at least, had had multiple events of transverse myelitis, and they compared different things that they'd tried. So IV solumedrol by itself, IV steroids plus plasma exchange, IV steroids plus IV cyclophosphamide, which is a fairly aggressive immune suppressant. Some would call it chemotherapy. IV steroids plus plasma exchange plus cyclophosphamide. And basically they found a hint that maybe in people that had the most severe spinal cord lesions, that they got somewhat better if they had the combination of all of these things early on. So the plasma exchange and the cyclophosphamide. This is not a definitive study. I'm sure Dr. Greenberg would be the first to tell you that, but it provides a hint that maybe there's more that can be done by using combinations of therapies with different mechanisms to try to enhance recovery. All right, so I'll just close with a summary of the things that we know about and can use, all of them generally off-label for acute treatments. Corticosteroids, generally the first-line option. Many people, though not all, will use plasma exchange as a second option, especially in neuromyelitis optica, but we'll try it in any of these disorders. IVIG may have a role for some patients, and then the combination therapies, I think, hold some promise. What we really need, of course, are ways to prevent inflammation. That's what you'll hear about next. More effectively treat inflammation and then affect repair, which I think is the next frontier of this type of multi-headed treatment, if you will. So I'll stop there. If there's any time left, I'm happy to answer questions. Otherwise, we'll move on. Thank you. So the question was, why only, did you say 5 plasma exchange treatments? Yeah. Well, I guess I couldn't say for your very specific situation why that was decided. Again, there's not necessarily a right or wrong way to do plasmapheresis. When we do it at Mayo Clinic, we typically follow Dr. Weinshenker's original protocol, which is 7 exchanges done every other day. However, if one looks at the science of what happens in the blood, and you measure things like antibodies, and you ask the question, well, how many and how often, how many times and how frequently do I have to exchange to take almost all this stuff out? The answer is actually 3 exchanges. So doing 5 might add a little bit more. Doing 7 adds a tiny bit more. You know, the longer one has a line in, and the more procedures one does, the higher the chances of the complications. And then we generally do it as a course, thinking that we're pulling away something that's causing that acute attack, and we don't necessarily continue it any longer than that. now again, as I mentioned before, in the future, we may find that there's actually a role for plasma exchange as a preventative therapy where somebody could get plasma exchange periodically. Sometimes out of desperation, in certain situations, we've tried that. And of course, back in Dr. Weiner's, at the time of Dr. Weiner's original studies in the 1980s, that was the idea for multiple sclerosis, that repeated exchanges might be helpful. Now, they actually concluded at the end that it wasn't helpful, but that was another era, and they were mixing together people with progressive MS and relapsing remitting MS. It's very hard to know, what answer we'd get today if we think we're smarter today, that we would take, a little bit more, we would be a little bit more selective about the people we put in those trials. But I think if you had 5 exchanges in a short period of time, you could be pretty comfortable that, you had taken the vast majority of these substances, whatever they are, that we're trying to remove out. You're welcome. Yes, sir. Yeah, so the question is, what kind of evidence would we need to use plasma exchange as a first-line therapy instead of corticosteroids? Well, that's a very good question. And I will tell you that there are instances where in an individual person, we have had the experience of 1 or 2 attacks with them where plasma exchange was very helpful and their initial course of steroids was not. And so if and when they had another attack, we were just going to put them right in the hospital and start plasmapheresis. But that was based on that individual person's event. I think you should recognize that the use of plasma exchange is quite regional. So although we use it a lot and we use it as second-line therapy and others do as well, there are many neurologists who don't believe in it quite as strongly as we do or have other preferences. They might use IVIG first. Some of them don't use plasmapheresis at all. Probably to change the community's mind as a whole, or the majority of the community, it would actually take a formal trial like I described with Dr. Weinshenker's efforts, where one actually compared the benefit of immediate plasmapheresis versus immediate steroids to demonstrate that one's better than the other. So I couldn't tell you that one's better than the other. And many times we're using them in somewhat different people or different types of attacks, I should say. Almost everybody's getting steroids first, so we're treating the milder, the moderate, and some of the severe attacks, all with steroids, but we're saving the plasma exchange for some of the worst attacks. So it's apples and oranges a little bit, but I think, frankly, that's what it would take. Good? Thank you very much.